However, of course, top peoples are around in the rooms as well. Today in gynecology, we will have two defense, one and next to each other. So we will have two exams in the row. One of them is István László Baradács, who is more than welcome him to be here, and Anna Evelyn Juhász. She also will give a presentation. And I am also very pleased, and it's an unbelievable honor for us that we can welcome Bart Fauser, member of Academy of Europea, which is the largest academy in Europe, having more than 5,000 members and 92 Nobel laureates. And he's joining us to act as a chair of the unit. He's a really well-versed, renewed reproductive endocrinologist, best known in his pioneering work on the ovarian physiology and stimulation and IVF. And if I told his name also in Barcelona last week that somebody is coming, everybody said that, wow, this committee is really a professional one. But of course, the committee is not only have one members, but we have really today 8 people in the committee. So I'm also very happy to welcome our other international examiner from Bucharest, Romina Marina Sima. Thank you very much for coming over. So first, have a 2 applause for the 2 international ones to come and to act. But of course, we have also from Hungary, from Pécs, Bálint Farkas, very welcome to be here and being with us. We also have from Semmelweis University, Dora Kocka-Balogh, who is here. Thank you for coming over. We have Tamás Marton from Semmelweis University. Welcome. Gábor Varga, who is most probably known by you because he's the Vice Director of Center for Translational Medicine. Thank you, Gábor. And of course, the committee is extended also with 2 experts in methodology and in biostatistics. So Victoria Barna as a methodologist and Réka Tóth as a biostatistical leader will also join us. And thank you very much indeed. And I just would like to say good luck for the candidates and thank you.
The members of the committee and the audience, it's my great pleasure to introduce my PhD student, István Baradács, who was born and raised in Berettyóújfalu in Hungary, where he also attended Arany János High School. He continues his studies at the University of Debrecen, where he obtained his medical degree. During his university years, he was actively involved in scientific work for 3 years under the supervision of Professor Dr. Robert Póka, focusing on endometrial cancer. Since 2020, István has been working at the Department of the Obstetrics and Gynecology in Semmelweis University, where he successfully combines clinical activity with research and education. He started his PhD studies under my supervision at the Translational Medicine PhD program in 2021, focusing on gynecologic oncology, with special emphasis on novel molecularly targeted therapies in ovarian cancer, particularly PARP inhibitors and anti-angiogenic agents. István has demonstrated analytical precision and a deep sense of scientific curiosity. His commitment to excellence has resulted in 2 first-author publications in respected international journals and numerous presentations at national and international conferences. Beyond his professional life, he enjoys sports, playing music, and spending quality time with his family and friends. I'm confident that today's presentation will reflect the same clarity and enthusiasm that have defined his entire PhD journey. Please listen to Dr. István Baradács with attention and enjoyment.
Good morning, ladies and gentlemen. My name is István Baradács, and let me present you my PhD work, which is about PARP inhibitors in ovarian cancer. Let me introduce our team. I'm a resident doctor at the Department of Obstetrics and Gynecology at the Semmelweis University. My supervisor is Balázs Linner, or SMS is Brigitta Teutsch, And my vision is that the molecular targeted therapy could completely change the oncological treatments. And the mission behind my work is to learn about the possibilities given by this targeted therapy and bring the knowledge back to the bedside. We have started to work on two different projects. The first one is a meta-analysis investigating the PARP inhibitors in advanced ovarian cancer, and the second one is also a meta-analysis investigating the efficacy and safety of combinational therapy with PARP inhibitors and anti-angiogenic agents. Before I will present you my own results, I would like to give you a broader medical background for this case. Ovarian cancer is one of the most lethal gynecological cancers, and over 90% of the cases it rises from epithelial cells. For decades, we thought that it originates from the ovary itself, but the real troublemaker is living next door. It's the femoral end of the fallopian tubes, and because of the monthly menstrual cycles and ovulation, these cells are exposed to oxidative stress because of the ovulation, and that's why the DNA damage accumulates and the cancer is growing. This cancer has no early symptoms, and we don't have no effective screening method, so that's why it's a silent killer and a very big enemy in our targeted therapies. And the standard treatment for the ovarian cancer remains the cytoreductive surgical therapy and platinum-based chemotherapy after it. It's a powerful process, but it's far from perfect, and that's where the PARP inhibitors are entering the picture. So my first project is investigating the efficacy and safety of PARP inhibitors in ovarian cancer. Over 75% of the cases, ovarian cancer is diagnosed at an advanced stage, and with the standard therapies, relapse occurs in over 70% of the cases. That's why we need some new medical therapies for these cases and these cancer type immediately, and based on the early results of clinical trials, these kind of drugs could be the PARP inhibitors itself. So as a young scientist, I had a clear aim to assess the efficacy and safety of PARP inhibitors in advanced ovarian cancer. My methodology and research framework was based on a classic but powerful approach to search for all of the articles written about PARP inhibitors and collect all of the data of them. At this time, I didn't treat patients. The studies treated me. My study design was based on the protocols of Cochrane, and we searched in 3 major online databases, and our eligibility criteria was predefined in our PICO. 2 independent authors did the search, the selection, and the data extraction processes. Our quality assessment was made by risk of bias assessment tool and the grade online system. Our statistical analysis was made by R, and the interpretation, the visualization of the results was made in forest plots, of course. So we ran our systematic search and we found more than 9,000 articles. We went through them based on the PRISMA checklist, and we found 23 eligible articles for our meta-analysis and systematic review. The first and most important result in our meta-analysis, on this slide, this is a forest plot. We are representing the progression-free survival in aggregated forest plots in newly diagnosed and recurrent ovarian cancer. On the left side, you could see the settings for the investigation. It was about recurrent ovarian cancer, newly diagnosed ovarian cancer, and the patient subgroups and the treatment subgroups. Here you could see the hazard ratios with the plots. On the right side, you could see the statistical heterogeneity and the certainty of evidence based on grade. You could see that in most of the cases, the therapy with PARP inhibitors are produced statistically significant benefits in almost every patient group compared to placebo. Okay, and on the other slide, the adverse events is one of the most important measures of tolerability in these kind of investigations. Here you could see that we are investigated the adverse events in recurrent ovarian cancer, and the PARP inhibitors were compared to placebo and chemotherapy. And based on our investigation, compared to placebo, the PARP inhibitors emerged the risk of adverse events, but compared to chemotherapy, it was kind of the same. There was no statistical significant difference between them. As we know that before, the PARP inhibitors have a harmful effect on bone marrow, and based on that, the risk of severe hematological adverse events was highly elevated. But it's important to highlight and mention that in most of the cases, these kind of adverse events could be managed in the vast majority of the cases by dose modification, and treatment discontinuation was needed in a smaller portion and smaller percentage of the cases. So most importantly, we do our systematic review and meta-analysis based on phase 2 and phase 3 RCTs in PARP inhibitors. We did it according to PRISMA and Cochrane standard. The protocol was registered in Prospero. The whole meta-analysis included 16 RCTs with more than 5,000 patients. And the most important benefit was that the PARP inhibitors elevated and significantly improved the progression-free survival across almost every patient setting. And the greatest benefit was observed in BRCA-mutated and HRD-positive populations. The safety profile was acceptable, and these drugs are well tolerated. One of the most frequent adverse events was the hematological adverse events. So I will continue with my second project. It's investigating the efficacy and safety of combination therapy with PARP inhibitors and anti-angiogenic agents in ovarian cancer. So as I mentioned before, ovarian cancer is a very big challenge, and because of the late diagnosis and with the high relapse rate. PARP inhibitors revolutionized the treatment of ovarian cancer because they are targeting the DNA repair mechanism, and they have a high effect in cases when this DNA repair in BRCA mutation and HRD-positive cancer is defected. But it left a big subgroup of patients who don't have these kind of mutations. The PARP inhibitors leave them without a solution. On the other hand, we have the anti-angiogenic agents, which blocks the VEGF pathway and inhibits the tumor vascularization. And they are also proved significant progression-free survival benefit in the trials before, but the resistance for them is emerging. So based on preclinical studies, it could be a good idea to combine these two kind of targeted therapies, and maybe they have some synergic effects. Like anti-angiogenic agents, they induces hypoxia, and based on this, they downregulate the BRCA1 and the RAD51 genes in the DNA repair, and they are increasing the sensitivity for PARP inhibitors. And on the other hand, both of the drugs are, have an effect, a synergic effect on tumor microenvironment. So as the years passed, I got a little older, my weapons evolved, and I had two new aims to assess the efficacy and safety of this combination therapy. Our research framework was kind of the same. It was, the design was based on the PRISMA and Cochrane standards. We did our systematic search and data extraction as the same way. We do the quality assessment in the risk of bias assessment tool and grade approach. And we did our meta-analysis in R. So here is the first result for our second meta-analysis. This plot, this forest plot, is representing the efficacy of combination therapy compared to PARP inhibitors alone in recurrent ovarian cancer. On the right side, again, you could see the patient subgroups with the different studies. And here you could see the hazard ratios. In this kind of investigation, we didn't see a significant clinically or statistically significant benefits toward the combination therapy. Interestingly, there was a trend forward in the BRCA wild type patient group, but it wasn't statistically significant too. On the other hand, we investigating the adverse events, the serious adverse events in this kind of patients. And we saw that there isn't any big difference between PARP inhibitors alone or the combination therapy. So it's kind of good. But we could predict that, based on our knowledge, that the anti-angiogenic agents are raising the blood hypertension risk. And our meta-analysis underlined it. The risk of hypertension was elevated. It's about severe hypertension. In this case, the systolic level it's above 160, and the diastolic level is above 100. To summarize my second project, we had 6 RCTs with over 2,000 patients, and there wasn't any significant benefit for the combination therapy compared to PARP inhibitors or chemotherapy. There was a good trend forward in the BRCA wild type subgroup, and it's important to mention that we found only one study which investigated the newly diagnosed patients with combination therapy, and these results showed significant progression-free improvement. For the safety parameters, these kind of drugs and this kind of combination therapy is well tolerated, but the hypertension risk is increased. Okay, so for that, these kind of combination therapy sounds good in a biological or molecular level, but we need more clinical evidence to underline and use this kind of combination therapy in the real world, in the real patient treatment. As a conclusion, the PARP inhibitors means a real cornerstone in the treatment of ovarian cancer patients. they had very significant progression-free survival benefits in our investigation, especially in the BRCA-mutated and HRD-positive patient population. The safety profile was well tolerated with a higher level of hypertension and diarrhea. For the combination therapy, there was no progression-free survival benefit, but the therapy was well tolerated. And for the implication for the future and the clinical side, for the treatment of these kind of patients, we need regular and systematic screening for the BRCA mutations and HRD positivity. And for the future investigations, we need to find some kind of biomarkers that could predict the toxicity and the resistance for these kind of drugs. Through the 4 years, I had the chance to work with very, very inspiring people. And one of them was the greatest, who started his work with us as a student researcher. And now he is our colleague at the gynecological clinic. And hopefully you will be invited soon to his PhD defense too. Thank you for your attention.
Thank you very much for this clear introduction of the discussion. So we have a full committee, opponents and experts. So we would like to start with the discussion and give the floor to the first opponent, Professor Sima.
Thank you very much. It's a great honor to be here. I congratulate you for your presentation. From my point of view, it was very clear and concise. And because I'm an opponent, I have to do my job. So I read your thesis and I was very attentive to the presentations from here. And I would like you to ask about the adverse events. You told us about some details about anemia, thrombocytopenia, and also treatment interruption. Can you give us more detail about the treatment interruption reasons? Was it caused by those side effects and those clinical effects or other reasons? This is my first question.
Thank you for your question. Yeah, it's a very important thing to talk about. As I mentioned, these kind of drugs is basically they are well tolerated, but in some cases they are elevating the risk of severe adverse events, severe toxicities. And as we've seen through the studies, in around 10% of the cases was stopping the therapy, was the intervention stopping was needed, and in over 50% of the cases the dose reduction was enough. The dose reduction with some supportive therapeutic care, like in the case of the severe hypertension, when the systolic measures are, the systolic results are above 160, they could immediately treat the patients with calcium channel blockers or ACE inhibitors. And for the hematological adverse events, they are it's a time to event adverse events, so they are not accumulating during the time. So if we having a pause in the treatment of the dose modification for the patient, the bone marrow could regain the quality of producing the cells of the blood, and the effect is not prolonging for a long time. Most of the cases, dynamic hematologic monitorization is needed. In these kind of patients, they are checking the levels of erythrocytes, thrombocytocytes in every month when the therapy is starting. And if any intervention is needed, they could start with transfusions, or in some kind of cases, they could give the patients EPO. And in this kind of way, the treatment could be continued for in 90% of the cases. And these adverse events were manageable, as we saw.
Okay. Do you have a second short question and short answer, or shall we move on?
Oh, a short one. Please. I have only one short question. Did you find any data about borderline ovarian tumor among your research? Because I saw on the reference list that you cited the EBSCO Colombo 2020 about ovarian tumor, fallopian tube, and borderline tumors. Short answer.
Yeah, in most of the cases for the borderline tumors, they don't use the targeted therapy. In most of the cases, these kind of tumors could be healed and completely treated with surgery itself. Thank you.
Okay, very good. Thank you. Then we go to the second opponent, Dr. Farkas.
Right here. Sorry. Okay. So first of all, congratulations. It was quite straightforward. My question is relating to the first study, when you mentioned that the progesterone-free survival with the PRRP inhibitors really helped. So how would you evaluate the level of statistical significance of your results in this case? Would you call it low-grade or high-grade certainty?
We did a systematic approach for this based on the grade system, the grade online system. If you let me, I will go back to this slide. And we also did a heterogeneity adjustment for the patients and for this kind of patients. And we saw that in most of the cases, the heterogeneity was quite low. If the significance was, the benefit was statistically significant, the heterogeneity was low in almost every case. And based on this could be very high-level data, but unfortunately, this is a new kind of treatment, relatively new kind of treatment, and we in most of the subgroups, we found less than 6 RCTs per subgroup. So the certainty of evidence was moderate to high, but in some kind of cases, it was quite low. So it's a hard thing to answer, but you should see that in this world, in the targeted therapy interventions, the EMA, the European Medical Agency, are evaluating and accepting the treatment with these drugs based on only one studies, because these kind of studies are very high level and they are really big worldwide international RCTs. So that's my answer.
Okay. One quick question. So you included PARP inhibitor alone, PARP inhibitor with the combination of the AIA medicines. Yes. So didn't you feel the need to include AIA alone? And the effect of that, that would be, I think, helpful to see what is it doing alone.
Yes, it's a very good question. And the answer for that is that the anti-angiogenic agents, like VEGF inhibitors, was used way before the PARP inhibitors in ovarian cancer treatment, and the questions about them is nearly all of them is answered yet. And the new questions about them is not the effect or the efficacy of them. The new questions arising that because the emerging resistance for them. So we didn't want to find a solution for the ovarian cancer in the case of VEGF inhibitors or anti-angiogenic agents itself. Our answer or big question and the theory was the combination therapy because of that. Because with the combination therapy, we thought that, and everyone is, to be honest, is thinking in the same way in gynecological oncology, that the problems with one kind of drugs in the targeted therapy could be handled with a combination. But we don't know the exact way to how to apply these kind of combination treatment for the patients. This is a question remained unanswered.
Okay, thank you very much, and thank you. Then we have three experts in the committee, and I would now like to give the floor to them to challenge you and ask questions. The first one is Dr. Martin.
Thank you very much, and thank you for a lovely lecture. My first question that I would like to ask from you is, what do you think, what is the reason behind the fact that the combination therapy did not work or did not improve the overall survival?
To be honest, I'm pretty sure that in the future it's going to be highly effective and usable therapy for a daily basis for this kind of patient. But at this state of art, we don't have enough long-term data and don't have enough RCTs to seriously mention these kind of drugs as a used as a daily basis. But based on the one trial that I mentioned, the Paula-1 trial, which is investigated the efficacy and safety of these drugs in newly diagnosed patients, based on these one trial results, the EMA accepted this kind of combination therapy for newly diagnosed patients without any restriction on the molecularity of BRCA mutations or any DNA repair defects. So I think in the future we could count on them.
Now, based on your experience, and you really dig very deep in the topics, what would be your recommendation using single agents one after the other, or how would you see the place of the PARP inhibitors or the anti-angiogenic agents?
For the real world part, you should see that these kind of drugs are used for a long-term therapies, for maintenance therapies, like for the PARP inhibitors, for example, for the olaparib and the rucaparib, the use of them for maintenance is more than 2 years, and because of this, you should count about the pricing of them, because one box of rucaparib with 60 tablets, which is enough for 1 month's treatment for the patient, and you should count for, in a good scenario, you should count for 24 months per patient. For 1 month, it's more than $5,000. Like it's more than $1.5 million forints. So it's a relatively serious and hard question for the decision makers. But there is no question about that. These kind of drugs are only used in highly impacted medical and oncological centers only.
Let me just have one more very short question. That's about yes. You did mention the short-term side effects of the drugs.
Yes.
Can you please comment on the long-term?
Yes. We also tried to investigate the long-term side effects. Like here you could see the myelodysplastic syndrome and acute myeloid leukemia, which if you think it could be a long-term toxicity, but here at this state of the studies, most of the time the term it wasn't more than 2 years, so we couldn't effectively counting with them.
Thank you very much. I would like to move now to expert number 2, Dr. Balogh.
Thank you. Congratulations for your presentation and for the whole work. I would like to ask that you wrote on your slides, safety profile is acceptable after your first study. Could you please explain a little bit about this? Because if I was your patient, I would definitely ask this. What is acceptable?
The acceptable, yeah, it's not the, maybe it's not the best term, but the right term is that they are well tolerated. So it's obvious that these kind of serious and long-term therapies have some side effects and some toxicities. But the term that they are well tolerated is born because these kind of side effects, all of them, could be manageable. So this is the answer.
Okay, and I have another short question. You mentioned you will need some biomarkers which can be used for monitor the side effects and the progression of the disease. Could you please tell us about a little bit this?
Yes, thank you. It's a very, very important question. And at this time, we only could measure the old school parameters like the hemoglobin level of the patients, the erythrocyte count, the platelet count, and in some kind of cases they are measuring the bone marrow itself. But in the future we need some specific biological markers, and these kind of biological markers should be search the hematological adverse event and the pharmacogenomics of these drugs too. So for the answer for the future, it could be that the dynamic hematological monitorization and the pharmacogenomics of gene investigation could together hold this title to have the biomarkers for these patients, maybe.
Thank you. Let's move to expert number 3, Dr. Varga, Professor Varga.
Doctor is fine. Okay. There is always a question whether you should be called as a professor or doctor. I mean, in different committees. That depends on the committee, I have to say. Can we go back one slide, I believe? Okay. I mean, first of all, very nice study, whole thing. I mean, you started somewhere and then you reached actually quite valuable outcomes, and then it opens the gates for many more questions. Here on the PARP inhibitors and versus chemotherapy. I mean, the first one is significant. With BRCA mutations, that's significant, and with no mutations, that's not significant. So this is coming, although the direction is pretty much the same. So is this coming from, I mean, it could come for many different things. I mean, the BRCA itself, but maybe some other things. So could you explore this?
Yes. This is because the first theory and the most important one is that the PARP inhibitors could be very effective in these scenarios where the cancer cells itself have some kind of DNA repair defect, like in the BRCA-mutated ones and the homolog recombination deficiency. Based on these, this side is enough for a single strand break in the DNA. And on the other side, the PARP inhibitors are targeting only the PARP enzyme itself, and they block the PARP enzymes. And the PARP enzymes are also playing a role in repairing the one-strand DNA breaks. And if this kind of two scenarios happens in the same time, this is the time where the PARP inhibitors could be very effective. But the BRCA mutations, the germline and the somatic BRCA mutations, in the germline mutations, you investigating the tumor and the patient, so in all of the cells, there is a mutation, and the somatic mutations, you are investigating only the tumor cells, etc. The point is that in these cases, the investigators and the scientists think that there are more of these gene repair mechanism which plays a direct role in these kind of patients. So we know about the BRCA mutations, and we are investigating them and try to find them and doing our subgroup analysis based on them. But based on the thesis, there could be a very big circle behind them with a lot of other homolog recombination deficiencies that at this time we couldn't investigate.
That's one thing. I mean, the way as you think is very good and very nice. But we also see that in the group of total population, heterogeneity is 85%, and the certainty of evidence is very low. So yes, that is another thing, because, I mean, the speculation is very fine, I mean, what you said. But this has to be proven. And then the point is that you see that when there are lousy studies, I mean, this is not your fault. I mean, this is just, I mean, handle the data what you have. I mean, that suggests that actually quite a few studies are not perfect. Okay, so for this reason, actually, although you have almost the same effect on that group too, but some of the studies may not be that good. And that actually, that comes next to my other question, which could be very short, about the future, actually, because you concluded in the second study that more research is needed. Just very, I mean, really, just very briefly. So, the number of studies are small, but are there actually quality problems with those two, which should be improved in order to get a kind of correct answer or high level of evidence for the second one, for the combination study?
For the combination studies, the heterogeneity was high, and from the 6 RCTs we found, 5 of them was made on an open label manner, and one of them was unfortunately only a conference abstract. So we couldn't tell the baselines of patient blinding and randomization process based on them. So this could be also a very important role in the heterogeneity. So that's why we need future trials. Thank you.
Regarding your second project, you mentioned that we should find some biomarkers for screening toxicity. What kind of biomarkers should be or would be suitable for that?
These kind of biomarkers are not predicted they are not predicting the toxicity. They are predicting the chance, the risk for a higher toxicity. And at this time, we don't have no genomic biomarkers for them. But in these kind of cases, we need some kind of bone marrow epigenetic regulation genes to find, I think, but I'm not working at this field. But based on based on the studies, it could be one.
Hi, congratulations on your presentation. I'm still, I think, on the level of evidence question. I'm not sure if I've seen anything about the risk of bias here. Have you shown it about your studies, or do you have only the certainty of evidence here?
At this presentation, I haven't shown the risk of bias assessment, but it's included in my thesis for both of the studies.
I'm just wondering, like, what were your most important outcomes here? How you consider them critical or not for the certainty of evidence level? And how you came to a reasoning in the end, because we see here you have many outcomes and then you have different assessments for each one. We come from high to even very low. But how have you seen, like, overall to have your final answer on your results on the level of evidence of this? What have you considered? Why you have some that are so high in certainty of evidence but some very low? So I just wanted you to maybe disclose more about this.
Yeah. Thank you for your question. In most of the cases, the differences was based on the different definition of BRCA mutation and any other DNA repair mechanism mutation. So it was on the diagnostic side because in the different studies, the definition of HRD mutations, which is the bigger part of the BRCA mutations, the definition of them was differed. And that's why we don't have a real strong consensus in these kind of patients. As you could see, the lower evidence was based when a very specific gene mutation is investigated, and here also. So this could be an answer. And in 3 trials, they used a specific trademark genetic test for these kind of DNA repair defects. And on the other ones, they used a very different one. So based on these, it's a question that are they comparable or not?
Okay, okay. So thank you, dear candidate. Thank you for the audience and the committee members for this fruitful discussion. And we will now withdraw and come to a conclusion. Thank you. Well, yeah, I can see both the candidates are present. Before we move to the closure and the official announcement, I would like to thank all the committee members. Number one, the audience for being present and for asking questions, participating in the discussion. Very, very good. And I would like to congratulate also certainly Semmelweis University for arranging this, because you will see that the committee overall was very, very impressed by both candidates. So then let me invite candidate number one, Dr. László, could you please come forward? So I can inform you officially that your PhD is granted with a high scoring of 93%. So my sincere congratulations. Very well done.